Ashok Kumar Nanda, who is a very senior cataract and refractive surgeon from Bhubaneswar, to please deliver the keynote address.
Thank you, ma'am. A very good afternoon to all of you. We all know that posterior capsular rent is an unwanted guest, and as Indians, we treat guests with respect. So let's treat capsular rent as we treat our guests. The goals of managing PCR are three. We must avoid dislocation of nucleus or fragments or cortical matter into the vitreous cavity, prevent enlargement of the tear, and prevent damage to the capsular axis. In addition to this, we must try and do minimum vitrectomy to remove all traction, remove all leftover cortex, maintain wound architecture. Proper decision about IOL placement is also equally important. So we follow certain strategies. First, to decide about our strategical management of the PC rent, we must know the extent of the tear, intactness of hyaloid face, the size and hardness of the nucleus, location of the nucleus, whether it is in the antechamber or it is already dislocated into the vitreous cavity, the availability of equipments which are necessary to rescue, our knowledge about vitrectomy, alternative IOLs which are necessary in case you have to change your plan, and availability of a VR surgeon with you. Early recognition is an important step. Sudden deepening of antechamber with momentary pupillary dilatation is the key. Sudden appearance of red reflex peripherally and difficulty in rotating the nucleus are also signs to make you aware. Stabilizing antechamber is the first step of management once you see a rent. Do not withdraw the instrument from the antechamber after the rent. First, inject viscoelastic into the antechamber and then remove the phaco probe or whatever instrument is there in the antechamber. Second step is to plug the PCR. A large amount of cohesive high molecular weight viscoelastic is injected through the rent to separate the hyaloid face, and then effective barrier is created, and we fill up the antechamber with dispersive viscoelastic and continue with the surgery. If the rent is small, we convert into a small PPC and then continue with the surgery. However, if it is big, then we have to first segregate the fragments of the lens which is there. Viscoelastic trap technique is where you inject viscoelastic either from the side port or pars plana and elevate the fragments towards the corneal endothelium and then continue with the surgery. We need to decrease our parameters, switch to low fluidics, low flow rate, low irrigation pressure, low vacuum. These things will be dealt with as the IC progresses. And scaffolding so that the nucleus doesn't drop is essential, and we can use a 3-piece IOL placed in the sulcus or a single-piece IOL placed in the bag, whichever is convenient. It blocks the vitreous from coming into the antechamber and getting aspirated, and you can continue with the surgery without the risk of the nucleus dropping or vitreous being pulled into the phaco tip. So in case the nucleus is dropping, if it is a large whole nucleus dropping, a posterior levitation is done with a 26-gauge needle from the opposite side pars plana, and it is lifted into the antechamber. If small pieces are dropping, then we do the vitrectomy and put a lens as the judgment gives. If it is a small and soft piece, the lens is fixed. If it is a hard or a large piece, then it is left to the VR surgeon to complete the surgery. PCR with hyaloid face, if it is ruptured and the nucleus is already in the anterior mid-vitreous, do not fish out the dislocated nucleus. It increases not only the tear, but it also increases the risk of retinal detachment by causing peripheral tractional tears. So regarding vitrectomy procedure, again, we have speakers to talk on it in details, but a 23 or a 25 gauge vitrectomy cutter is necessary, and bimanual technique is better with a separate infusion line. Use maximum possible cutting rate, at least 2000 cuts per minute, and low vacuum and low flow rates are necessary. Vitrectomy cutters should be advanced to the PC rent, just below it, and held stationary with the aspiration port looking up towards the cornea, and vitrectomy is completed. The anterior vitrectomy should be started with preferably dry vitrectomy, and once the chamber is starting to collapse, the BSS can be gently infused. Vitrectomy should not be done through the main port, rather from the side port, and all vitreous tags should be removed after staining with a triamcinolone. There are possibilities when you have to convert, and ideally, if you convert when there is a large PCR or a large retained nuclear material, especially if it is in the early part of surgery, there is a large nucleus material left, very hard cataract, small pupil, or if the surgeon is novice, then it is better to convert. You can either convert as an extension of the wound, making it a ECC, or do a separate sclerocorneal wound and complete the expression of the nucleus with either visco-expression or hydro-expression. When you have to take a decision about IOL placement, make sure the pupil is round and be certain that the incision has no vitreous tag, there is no traction. Evaluate the intactness of your CCC so that sulcus fixation can be done. If the PC rent is small, you can put it in the bag. PCR is converted into PPC, then in the bag placement is ideal. If it is large, put a 3-piece lens in the sulcus and do an optic capture. If in case the rent occurs when the lens is being inserted and it's a single-piece lens, then you can do a reverse optic capture provided your CCC is small. If you are in a dilemma to know whether your lens is stable or not, you can do this test. You can actually push the optic to one side and see if it is bouncing back to the center. If the haptics are well supported by the peripheral part of the capsule, then it will come back to the center and you are sure that the lens is in place. We are likely to encounter with certain complications which we have to manage meticulously, and of them uveitis, raised IOP and endophthalmitis are of importance. In later stage also glaucoma, epithelial downgrowth and increased risk of detachment is also quite common. To conclude, early recognition and treatment of capsular tear, vitreous loss prevents serious complications and improves postoperative outcome. In case of nucleus drop, do not fish out, remove the vitreous tag, do a vitrectomy, decide appropriately about what IOL to be put, and then go ahead. Anterior vitrectomy should be done with high cut rate and minimum movement of the tip of the cutter. IOL implantation needs proper judgment. Thank you.
Thank you, sir. I think that was a very good overview and sets the stage for the other talks as well. Please join us in the panel.
Thank you.
Thank you.